everyone, and welcome back to another episode of the Core Consult RX podcast. My name is Mike Corvino. With me, as always, my co host, Cole Swanson. And today we have a very, very special guest. We got Brian coming in all the way from which hospital, Brian?
Wesley Medical Center in Wichita, Kansas.
There you go. We're going to be talking about traumatic brain injury. So I'm going to let Brian kind of introduce himself and give a little bit of his background. And then we're going to talk about kind of his steps in doing emergency medicine and going through his residency and all that, looking at critical care. And then we will look at a traumatic brain injury case. And this one will be a little bit different because we're not going to go so in depth with the case, but more so like the algorithm of dealing with such a complex issue like traumatic brain injury.
Mm-hmm.
So, Brian, give us the history.
All righty, the history, the 30-second history. So I actually did my undergrad training and studying at the Florida State University in Tallahassee. I got my bachelor's in about chemistry, in that area. Was thinking maybe medicine, also pharmacy. Really, when it came down to it, I was able to shadow both a physician and also shadow clinical pharmacy specialist, and decided that was the path I wanted to take. Applied to pharmacy schools and actually was able to stay within the state of Florida. Did my training at the University of Florida. Graduated in 2015. During my time in curriculum and training at the University of Florida, developed a passion for critical care and sort of these complex patient cases, and this sort of algorithm or way of not always having the black and white answer that pharmacy school kind of pushes on you a bit. Was able to actually do an internship program at the Johns Hopkins Hospital in Baltimore, and was able to actually spend a summer in the critical care pharmacy satellite there. Actually did patient rounding, was able to be part of a research project, at which point we were able to get that published. And so it's just really from the early stage of pharmacy, our pharmacy school was able to really hone down. That's exactly what I wanted to do. I was lucky because I know that a lot of people don't always get that, but second, third year pharmacy school, I was like, I knew I wanted to be a critical care practitioner. So I knew that I needed to go down the residency pathway for that. So started looking at different ways to try to make my application as competitive as possible. Was lucky enough to be able to do a PGY1 residency at Jackson Memorial Hospital in Miami, Florida. Very large hospital, very big institution. Miami is a very almost unforgiving place at times. So it was really a great place to train because the patient population was so acutely ill. So it was definitely a learning curve there in terms of delving into the critical care aspect. Then was able to apply for PGY2 in critical care, and landed out here in Wichita, Kansas, where I did my PGY2 in critical care. And during my residency, I was trying to figure out exactly what I wanted to do. I knew I loved emergency medicine. I knew I loved trauma. I knew I loved neurocritical care. So applied for jobs and positions out there for that. But when it came down to it, I was able to get all of that into the position I'm in now, which is more emergency medicine, trauma, and neurocritical care all into one at Wesley Medical Center, primarily working out of the ED. So it's been great. And we've actually started services. We've been doing it now about 5 months, and it's been a lot of work, but it's also been very rewarding.
Awesome. And for those of you who aren't super familiar with a pharmacy residency, it's pharmacy graduate year 1 and 2, and generally the first year is a general residency where you see a lot of different things and kind of almost rotate like you would during a clinical rotation. And then the second year is much more specific into what you're going into, like critical care. And that's how it was for you?
Yeah, absolutely. So I kind of correlate it to your PGY1 year is more of your internal medicine year, where you're doing every aspect of training, whether it be you're doing outpatient, you're doing infectious disease, you're doing internal medicine, cardiology, critical care, you're doing emergency medicine. So all of these are wrapped into one, where you're not able to really specialize at that point yet because you're not really trained at that point to be able to do that. It's also great in that the first year, with it being so well-rounded, you get a better overall look at the whole patient stay for the patient stay. So I mean, you go from the early stages of outpatient therapy to they get acutely ill, they go through the emergency room. Now they're in the ICU and they get better. They're going into the floor, and now they're off again back to the outpatient setting. So they actually get a great overview of that, and it can be frustrating at times because your heart's pulling you towards critical care or another area, and then at that point you still need to give your all to that rotation. But yeah, it's a great first year, and then second year is even better because you're able to just dive deep into the area that you love and try to figure out exactly within that area what's my subspecialty going to be. So critical care patient, there's different aspects, but then within the trauma patient, there's different nuances that go on as opposed to a medical patient. So
Right.
yeah, that second year is really where you figure out, not only do I want to do this aspect of medicine, but a subspecialty of that. So
Right. Going through PGY 1 year, was there anything that drew your interest and was like, hey, this is pretty interesting too? And if you had decided, say, you wanted to pursue that, did you have that option, or were you kind of stuck on critical care at that point and couldn't really get out?
and unfortunately, the way our training with pharmacy is that you have to know pretty early on what you want to do in that second year, because the application process happens so very fast.
Right.
You usually get into a program in July, sometimes
really?
maybe June if you're lucky, and then by December you're already sending out applications. And so if you're not 100% sure, it's always good to schedule those rotations early on so that you can kind of get an idea of, yes, this is what I want to do with my life, or no, I don't want to do this with my life.
Right.
And then there may be something that springs up on you that you didn't know about. There's plenty of stories out there where, not like mine, where I was just dead set that's what I wanted to do, but there's other people that have those stories that, hey, I kind of fell into my job and I absolutely love it. So
Cool.
That's awesome, man. So, with all your training and you're so specialized in emergency medicine and critical care, do you feel like that you could jump into another role, say, family medicine or something like that at this point, or is that just too far gone, or do you feel like you could easily retrain yourself and go back?
that's the great thing about having that first year of residency. Would I feel as comfortable as somebody that has done it or been specialized in it? Probably not. But that's the kind of the whole point of that first year, is to give you exposure to that, so that you're able to jump into that if needed. I would say it's a little bit more difficult to go from specialty to specialty. Depending on the institution you work at as well, is probably going to be a big factor as well. So if you're specializing in emergency medicine or critical care and you try to jump into infectious disease at like a large academic medical center, it's probably not going to happen.
Right.
But you could go to maybe a smaller community hospital that is trying to start up their infectious disease program and say, this is what I've done. And so you could probably do it. It's not impossible, but it's definitely makes your path a little bit more difficult.
Yeah, that makes sense. And that's probably how it is for most professions. Once you specialize and you're there in it for a while, it's hard to bounce back out and go to something else, but it's possible. Well, cool. So talk about a little more specific about what you do on a day-to-day basis. So what are your hours like, and what do you usually see as far as patient population?
Yeah, so that's the best part about my job, is I literally walk in and I have no idea what I'm going to see. You can start the first half of your day and it can just be, you're not supposed to say it, but it can be quiet or calm.
Right.
And then all
Knock
of a
on
sudden
wood.
all hell breaks loose. You can have a 3 or 4 car pileup that all of a sudden now your trauma base full where it was empty and you had crickets going on earlier. So in terms of what I get to see, it's really all aspects and all spectrums of patients. In the emergency department, you have a wide range. Usually starting off at triage, there's a triage nurse or somebody there that's assessing how sick this patient is once they hit your doors. And then they get, again, they'll get assorted or stratified based off of that level to either, things like urgent care type deals that maybe aren't quite as acute as like the guy that just got shot in his leg. Right. So, there's all different levels of triage and there's a whole system on that. But the good thing about emergency medicine is it's probably every aspect of pharmacy rolled into one. So I see aspects of outpatient pharmacy. I see aspects of internal medicine, infectious disease, critical care, pediatrics. I mean, I see quite a big spectrum of patients. My daily activities include, just making recommendations to physicians and providers on the acute care of these patients, whether it be, antibiotic related or it's pain related, or all the way up to a critically ill patient that I am, managing their pressors or managing their sedation at that point after they've been intubated. If they haven't gotten intubated and they're about to get intubated, I will look at rapid sequence intubation meds. It's a whole spectrum and it's a lot and it's fast paced. But for the adrenaline junkie type pharmacist, this is probably the best route for you.
For sure.
Hours wise, I do 7 days on, 7 days off. And I do 10 to 11 hour days, sometimes 16, depending on the day and depending on the patients. Yeah. But it's definitely rewarding and it's definitely challenging all into one. But it keeps me on my toes, having to know really just a little bit about everything for each patient population.
Yeah, nice. For sure. So, what's your interaction like interprofessionally with the physicians or PAs or whoever's on the floor? How is your relationship with all of them?
Are they receptive?
Sure. So, we initially we haven't had services down in our emergency department. This is the first time we've done it. And so we actually had no idea what to expect going into it, my partner and I. But it's been so receptive. And really, it's all about just showing exactly what pharmacy can do in terms of not just logistics and operational type things, but that clinical aspect and showing them how well we are versed in the literature and coming up with good recommendations. It really just takes one or two really big recommendations to kind of, almost save their butt or make a great recommendation. At that point, they are going to be really super receptive. I would say too, your younger generation that have grown or trained with clinical pharmacists, it's so much easier than maybe an attending that's been a seasoned attending that's been there for quite a while.
Right.
They're not quite as receptive. And granted, they were, practicing back in the 70s when there was like 5 meds. So they knew all of them and they knew exactly like what to do. And so, sometimes when you have sort of your young hotshot pharmacist coming in there and saying, we should do this, this, and this. And, there's a little bit of medical dogma that goes on with your older attendings, which is, it can be good and bad, but for the most part, I would say it's not helping patients overall, because these older attendings teach the younger docs, and then it just kind of this cycle of almost ignorance sometimes. But overall, I would say it's they're very, very receptive.
Yeah,
that's awesome.
Cool.
I remember when I was a 4th year, one of my rotations I did neurology, and one of the neurology, he's the chief resident for neurology. I was him, and then me, and a med student, and then a couple other residents and things. And the med student asked a question that he wasn't really sure about. It was about a specific, like, getting a drug covered, like, by insurance. And I happened to know the answer to it, so I kind of told him. And their chief resident, said, awesome, thanks for that. And he turned around to the med student and he said, make sure whenever you end up and you're doing your residency, make sure you are super nice to your pharmacist. He goes, my pharmacist saves my butt, probably twice a day. And it was just really cool to see someone, because he was a super, super smart chief resident. I mean, this guy's going to be a phenomenal neurologist. And it was cool to see someone at that level still, respecting the PharmD that was on the staff, and appreciate that aspect of it, because I think that's one of the things that's been a struggle is, we've gone through such a big transition of like the guy with a bachelor's degree that puts some potions together and makes a compound to where it is now in such a short time. It's not so much as like, oh, well, we're let me just jump into this job. It's a lot of times like creating the job from nothing and
Absolutely.
and
Yeah.
earning the respect. So that's cool that you're getting to work directly with them. And
Yeah, and speaking to that briefly, I worked with a pharmacist just recently who's a little bit older, and she was working, way back when in the days of pharmacy, like you mentioned. And she said in school they discouraged counseling the patients on medications, and doctors discouraged it. Um, Essentially, if it wasn't what the doctor told them, you couldn't tell them otherwise. And I don't know, I couldn't imagine working in a pharmacy field like that, but that's how it was, which is strange. It has changed a lot.
And there's no going back into the critical care world for me. I mean, there's plenty of papers that have been published on the interdisciplinary role of a team approach for medicine that has shown such benefit to patients. Critical Care Medicine, or CCM, just published this month a paper on the utility of an ICU pharmacist, and they didn't see any mortality data, but they showed that length of stay and cost to the hospital and patient were both decreased, which to me are all wins in that situation.
Sure.
I mean, there's just so much literature there that we make a huge impact. And so, like you said, I don't see us ever. It's tough and difficult, but once we start phasing out some of those, older generation of not only just physicians and PAs and things like that, but once we're able to solidify kind of who we are as pharmacists as well. I don't know if we have that great answer of that as well, but I think we're moving in the right direction. One of the things I think that kind of hurts us as pharmacists sometimes is that on an individual level, your physicians and providers, they'll tell you to their face how much they love you and how much of an impact you're making. But then you get to their large organizations, and they're kind of anti-pharmacist at that point, which,
Is there an extra salary to pay for them?
Yeah, exactly. Scrambling for their own power at that point, which is fine in terms of, not wanting to give it up, but there's, the paternalistic model of medicine just doesn't work anymore. It's
Right.
just, it doesn't.
Yeah,
So,
and it goes beyond pharmacy. I mean, all around there's a push for interprofessional medicine, with quality metrics becoming so much more important, and people seeing that NPs and PAs and nurses can be utilized in ways that they hadn't been before. It's changing in I think a positive way.
absolutely.
And I think too a big factor that's going to play into whether or not pharmacy becomes even bigger than it is already becoming is individual pharmacists making a big difference as well. Because, and I'm talking, I work in community pharmacy, so I see this a lot where you can get by and do your job as a community pharmacist without necessarily spending a lot of time on continuing education, but that doesn't then play into, okay, well, how can I show them how much value I have? Because I'll talk to some community pharmacists that there's been a drug out for 4 months and they've never even heard of it, and it's something to treat diabetes, and I'm like, how have you not heard of this at this point? So, and I think it's huge on the pharmacist standpoint to look towards the future of the actual profession and see that we need to be pushing ourselves to learn more, utilize literature, and then constantly keep evolving as individual practitioners as well to actually make a name for ourselves, because it's only hurting us if we have a big group of pharmacists. It's not just community pharmacists. There's plenty of hospital pharmacists that kind of skate by too. It's just human nature, unfortunately. But I think that if we push ourselves and show the value individually, then it's going to eventually carry over. And all these new physicians, like you were saying, that have grown up and gone through school right alongside pharmacists have kind of recognized. I think I completely understand. I feel like the older attendings who, back when they were coming up, a pharmacist who was a guy with a bachelor's degree that worked in a shop. Like, if I was them, I probably wouldn't take the advice either. They didn't grow up with the same kind of pharmacist that we have now. So I think it's on the pharmacist as well to keep pushing that envelope and learning and showing the value.
And part of that goes into, like you said, staying up to the literature, but also creating the literature. So writing as much as you possibly can as a pharmacist, and to understand that the research projects that we create our own also has value. We're never going to have the large 2,000 patient randomized controlled trial. We're just not, unfortunately. But our data's, our studies can be designed to a way that the data can be relevant, and it can also help and impact patients. So
Yeah, absolutely. So kind of going on that, go off topic a little bit from critical care, but what's your thoughts? Obviously you're a smart guy, really well educated, done all this extra specialty training. What is your thoughts on, because obviously Cole and I push social media for a tool for learning and continuing education. What's your thoughts on that for, say, 10, 15 years out? Because there's a lot of schools, like we had discussed on the phone at the one point we first met, like there's a lot of schools that really encourage students to get rid of your Instagram and all these like horrible social media platforms that are destroying the country. Like, what's your thoughts on that for education?
So, it's funny. My partner is actually a guy that I trained with at the University of Florida, and so we brought him in. I was able to get him the position here with me, which has been great. But one of the questions he really likes to ask all of our residency interview candidates is how do you stay up to date on the literature? And he makes fun of me because I'm still trying to learn the best approach to utilize social media and its aspects for continuing education, because he's great at it. He follows all the right people on Twitter. He follows all the right accounts on Instagram and Facebook and things like that. I think that our generation is going to utilize its tools to the best capability, and to do that, you have to use social media. That's one of the reasons that I'm trying to get better at it. Is I'm not great at it. I'm still kind of an old school paper journal guy. I still get them delivered to the house. That
Awesome.
It's really funny. Yeah, I know you guys can laugh. I'm a millennial in a digital world here, trying to figure it out. But yeah, no, it has a role. Obviously, you need to maybe censor some of what you're doing in terms of your personal life, if it is something that is questionable. It's just like you see with every athlete that ever hits send. You're like, why?
Sure.
What an idiot! Why would you put that out there into the universe and then never get? Now you can't take it back. It's the same thing. I mean, I won't lie. When we get residency candidates, we do a quick Facebook search and see if you're out and doing things probably inappropriate. But I also have Facebook groups with the critical care pharmacy literature update for SCCM that we're a part of, and I get a lot of articles that I wouldn't have probably found otherwise, unless it was that, using Twitter for some of the toxicology pharmacists that are out there is great as well. And they can tweet out different things, and I think it has its role. I'm not exactly sure if we know what that role is yet, but I feel like, you guys putting on a great podcast like this, it's a step in the right direction. And it may be something that pharmacists in general could probably maybe take a hold of. I know that in terms of medicine, there's maybe a few guys, Weingart's out there, but and the Encrypt podcast. But other than that, I can't really think of too many medicine-based social media accounts that are probably as up to date or as thorough as pharmacists.
Sure. And as far as staying up to date, I mean, it's whatever works for you. So social media
Yeah.
is an option for people who that works for. Paper journals are an option for people who that works for too. I mean, me myself, if I'm reading a book, I like to have the book in my hand. I don't like to, use a Kindle, even though it is like super, super convenient. I prefer to like flip a page and read a book. And I like to get emails of new drugs that come out and new trials and stuff. I like emails, but I also use social media. So it's just whatever works for you. And developing social media in a way that is advantageous for a clinician, maybe someone who is younger and that's what they like, that's going to help them for sure.
I think you guys should design a class on the utility of social media and how you can use it to stay up to date with the literature.
There you go.
And then you can go into evaluating the literature as well.
There you go.
There you go.
All right.
Next podcast.
That's going on the list of to-do things.
So Rich from RX Radio, he's on Instagram. He's got a podcast as well. Him and I actually were just talking about that probably 2 weeks ago, because him and I are about to go. We met on Instagram. Realized he was another pharmacist from Miami, and this, him and his fiance and me and my wife are actually all four of us are going on vacation here in a couple weeks, which is pretty funny that we met on Instagram, and it's a tale as old as time, and so we're going out there, but we actually talked about So we talked about doing that and how that a class like that would look and what the future of that would look like. So we've talked about that. I think that'd be pretty interesting as well.
And also, I feel like it might be prudent to mention, even though we are both pharmacists and we interview a lot of pharmacists and we talk about a lot of pharmacy things, we do want the podcast to be helpful to any healthcare professional. So nurses, NPs, PAs, medical assistants, pharm techs, if there's ways that we can improve it to tailor it towards you guys too, let us know. mcorvino@coreconsultrx.com. That's
Boom.
my mid-podcast plug.
Yeah, mid-podcast plug. So, and kind of
Logo
yeah, we'll put something up there. The going off what you said too, I actually mentioned this when I was on Adam Smith's podcast. He's the Fit Pharmacist if you have for Instagram. When I was on his podcast, he asked about social media and things like that, and my comment was if you're too dumb to know that you shouldn't put a picture of yourself doing a keg stand on your public Instagram where people can see, you probably aren't smart enough to do a residency in the first place, and you don't deserve one. There you go. And I that's a little harsh and whatever, but like you were saying, you go and check Instagram, to see if it, or Facebook or whatever, to see if your coming on residents are on there and what they're kind of doing. And it makes sense. My personal Facebook page is wide open. Like anybody can go on there and look at it. I don't have pictures of me doing idiotic things, partly because I'm a dork and probably don't do anything cool that would get me in trouble anyway. But, nobody was really, there's nothing on there that would get me in trouble that I wouldn't want like a residency program or a hospital or whatever.
Or an employer.
To see, or an employer to see. So I think that's the big thing is why are you putting, if you have something to hide, to me, if like someone's like all private and like changing their name, that to me would be more of a red flag. Like, well, why? You're obviously hiding something. You're trying to pretend like you're this perfect student or whatever, and you're living a different life behind closed doors. So I think social media just kind of, exposes people to the reality of who they really are, not just, gets them in trouble. It's not like they just one time. Maybe some cases, but if you're taking a bunch of pictures doing crazy stuff, it's probably just because you do crazy stuff, not because that one time happened to go on Facebook.
Man.
It's probably a good idea too to use those view tools on those apps. Like, what can people see? What can they not see? But also to remember that, as we've kind of alluded to too, as pharmacy is a small world.
Oh,
so
yeah.
you're going to get asked about and asked around a lot. So, not being an idiot and putting stuff up there that probably shouldn't be up there. And then basically, like you said, asking the question, I always ask myself, would my mom be proud of this picture or not?
Right.
So
Exactly.
Yeah.
I'm also in the same category. I don't really do anything probably super outrageous. I'm as a dork as well.
We're all
So
dorks. That's the consensus here.
Nice.
3 dorks on a podcast.
So we have no business talking
on
about it.
Saturday night, rage.
I mean,
Raging.
it's a small world because 2 guys that graduated with Mike randomly, and you're out in Kansas, literally in Wichita, Kansas, and know 2 guys that Mike graduated with.
On purpose.
Right, on purpose. Yeah.
That's just something you don't see every day.
We got off topic, didn't we?
Yeah, totally off topic.
It's good though. We talk about whatever.
Yeah,
You learn a lot from this.
That's why I like podcasting.
There you go.
So cool. So bringing it back in, do you want to kind of go into the patient case so we can kind of like start working through the algorithm of traumatic brain injury and how you handle things?
Yeah. I mean, so are they going to have this available?
Yeah.
I'll put it on my website so they can download it.
We'll put it up on the website, coreconsultrx.com/podcast, and just scroll down to episode, what will this be, 7?
Yeah.
Lucky number 7, and it'll be there to click on. Or actually, it'll probably be on the front page for the time being, at least for like the next week or so. So there you go.
Awesome. When you start talking about critically ill patients and emergency medicine patients in general, and traumatic brain injuries being part of that, the first thing you really need to think about, and if you're in trouble as a resident or a student or a nurse practitioner, PA, whoever, or a young physician, is always going back to your ABCs. So airway, breathing, and circulation. Those should probably be your first questions at all time for these patients. Then specifically, when you start talking about TBI, you can probably break it down into 3 or 4 different categories in terms of their management. So the initial management will be the pre-hospital care, EMS, paramedics, whatever, that are taking care of this patient initially. So you need to know exactly how to treat that as well, or what's been done in the field before they get to you as a pharmacist. Second would be, once they actually get to your emergency room or trauma bay, how you're going to treat that as well. And then lastly, or third, would probably be once you've stabilized them, got them to the unit, and then after that, there's some other probably aspects to post TBI care that probably not going to be something to get into on this podcast, or that I'm not really able to speak about, but there are aspects of that care
Right.
as well, rehabilitation and things like that. So we can kind of get into the case initially.
Sure.
So I'll read it off if you'd
Yeah.
like.
Yeah,
But
that's perfect. Because there's gonna be some people who just want to listen and do not want to download it.
Right.
So go for
Which
it.
is okay. That's all right. If you're in your car and you don't want to download it,
Yeah.
totally cool.
Please just listen.
maybe it's the soothing sounds of my voice that puts you to sleep.
Yeah.
But this is so I say this, and this is literally the type of situation that you get on when EMS calls you on the radio. As you're, as I'm sitting in my office, I can kind of, I'm right in the emergency department. I can actually hear what's going on and what they see out in the field. So this is kind of what report you may get, either via EMS or once they get to your trauma bay. But we have a 22-year-old male with no medical, neurological, or psychiatric problems. They're brought to the emergency room after a MVA or a motor vehicle accident. Paramedics at the scene report that he had a GCS, or a Glasgow Coma scale, of 11, but then en route to the hospital, he deteriorated rapidly from a cognitive and behavioral standpoint. He has a GCS of 5 now, and his blood alcohol level is above the legal limit. No evidence of skull fracture, significant facial injury, or multi-trauma, although he has a few rib fractures. He's intubated upon arrival to the emergency room. CT scan is performed, and immediately we see a large left subdural hematoma. So that's kind of sort of your progression as we go of the TBI patient. And we can talk about, epidemiological facts of TBI. I mean, it's one of the leading causes of pediatric death, young adult deaths. In terms of incident rate, you're talking about 2.5 million per year will suffer some sort of TBI. So it's a very large problem that we have within the U.S. So for your civilians, you're going to talk about mostly the mechanism of injury is going to be motor vehicle accidents or falls. So you have a lot of elderly patients that are going to fall, and you'll also have these MVAs that come in, and usually they happen kind of, they're obviously they can happen at any sort of speed, but for your MVAs, it's really going to be high speeds that you see this. For non-civilians, you'll actually see a lot of blast injuries, which is really no surprise at that point. But it's a growing problem as well. The incidence of TBI has really risen probably over the past 10 years, and that's probably because we've had more access to more toys that go fast. So that's something to think about as well. In terms of pathophysiology, you can break it down as well. You'll have a primary injury, which is basically the injury that caused the TBI itself, whether it be some sort of external force, blunt injury, like we said, blast injury. There's really nothing we can do to prevent that. I mean, seatbelts, obviously, for MVAs, for children, if they're riding bikes or things like that, helmets on them. Those are things that we can do to try to prevent. But overall, the main theme for TBI management for healthcare workers will be the prevention and management of secondary injuries. That's usually vital and key.
Yeah, and to preventing, I guess, falls in the elderly, That might be one place where pharmacists can intervene if they have a lot of medications that are putting them at high risk for falls, you know?
Absolutely. When you start talking about the beers list
Yeah.
and things like that, that's a great point. That as an outpatient pharmacist, you have a great effect on that. So you can see those multiple syncopal agents that could potentially prevent that. That's a great point.
Yeah, and to those
Absolutely.
stats, I wanted to add a little bit that I thought was kind of shocking. About 50,000 people die per year from TBIs, and 230,000 people are hospitalized and survive from them, along with those millions that you said sustain them. So PSA, don't drink and drive, guys. Seriously, just don't do it.
Absolutely. The other thing too, when you say 250,000 or so actually survive, that's not even accounting for the morbidity afterwards.
Right.
I mean, these things can leave you very much disabled at this point. So in terms of your death toll and mortality rate, it's probably, functional mortality at that point,
Mm-hmm.
probably pretty high as well.
I think CDC says 80 to 90,000 people every year experience the onset of a long-term disability, and right now there's about 5.3 million Americans living who have had TBIs in the past, which is significant.
Absolutely.
Something I thought was pretty interesting was when I did my surgery and trauma rotation in school. I remember the attending talking about, we had a patient with a TBI come in, and the attending was talking about how often you'll see complete changes in personality after like a severe TBI if the patient survives, whether or not that's intellectual ability or they have anger issues and all these things. That's pretty fascinating as well because that affects the family and everybody else as well. It's
Absolutely.
pretty sad.
Probably the most famous TBI case, and maybe you learned about it in school, but Phineas Gage.
Mm-hmm.
So
I've heard of I've heard of that.
Phineas Gage received the metal rod through his left temporal lobe, I believe, and that's where he was like kind of this nice guy and peaceful, never hurt a fly, and then all of a sudden he turns into this, the Hulk. So that you're right. There's a high morbidity associated with the survivors as well, and it's not just once they leave, they're not done. And unfortunately, I mean, it's like I said, it's a growing problem within the U.S.
Yeah.
So good PSA there.
Yeah.
So yeah, when we start talking about these patients, the management of it is all around preventing secondary injuries. So secondary injuries begin right after the initial trauma, the primary trauma, and it happens on a microscopic and macroscopic level. So microscopically, you will have cellular damage, which will cause cytotoxic edema, which is essentially your intracellular contents are now being spewed out into the extracellular content. And then macroscopically, there may be blood that's actually onto the brain tissue itself, which is damaging. So those are sort of your main mechanisms of secondary injury. And the reason we focus on these so much is that we can prevent them or we can control them. And so that's sort of your overall rationale as to the importance of what pharmacists can do. Is we'll go into it a little bit, but managing these secondary injuries is key, and they're very vital to the patient's outcome.
And
so really the biggest two that we can guess, I guess we'll go back into the patient case. So
sure.
The first thing you want to think about, or the things that I'll take you through my thought process, and this is mostly guided by my interpretation of literature. If you ask another emergency medicine pharmacist, a neurocritical care pharmacist, a trauma pharmacist, they may have a different opinion on things, but overall, I'll go into my thought process on it. So I think 22-year-old male, he's got a TBI as per the paramedics and EMS being reported. He's got a GCS of 11. So at that point, we're not quite he's probably out of it, and it's tough to tell at this point, is the GCS 11 because he's got alcohol on board, or is it due to the TBI?
Can you talk about that a little bit? The GCS. Can you talk about the GCS score a little bit and what that is?
Yeah. So the Glasgow, it's a funny score, or not funny score, but it's an interesting story how it was developed. So it was actually developed in Glasgow, in the UK. And it was developed in the 70s by a couple of neurosurgeons that were professors at the University of Glasgow. And the whole idea of it was that these paramedics were trying to explain to the hospital and describe how these patients looked and how sick they really were. And what was happening was that they were saying, oh, well, we think they have a brain injury. Well, how bad is it? And they had really no way of knowing. So the neurosurgeons would have to be called into the hospital because they would have to evaluate, and they had no idea whether or not they'd have to take them to surgery or not. Well, the neurosurgeons kind of got tired of getting called in for brain injuries that weren't really all that severe. And so they ended up trying to develop this this scale to try to prevent them from having to be called in at 3 a.m. And that's really the rationale. It's bred out of pure laziness a little bit, but it's a validated scale that really just tries to stratify patients in their brain injury and their neurological status. For those who don't know anything about Glasgow, UK, it's probably one of the most violent cities in the world. They have a ton of TBIs and they have a ton of violence associated with that area. So this was kind of dubbed the TBI capital of the world in the late 70s, early 80s. So it's just an interesting standpoint that violence and laziness kind of created this now universal validated scale.
Right.
And actually we use it, it's a 15-point scale, which the original scale was actually used, it had 14 parameters to it. This is actually the one we use today is the modified Glasgow Coma scale, which is 15 criteria, but I won't get into it because I don't routinely assess for that, but it basically gets broken down into 3 parts: your motor, ocular, and verbal responses. And based off of the criteria, it will tell you, how severe this neurological injury probably is at this point. So it's a scale that goes from 3 to 15, 3 being very, very, very bad.
Right.
And 15 is what we are right now at this point. 3 is really just
That might be a 14.
no neurological function at that point. You may have minimal at best. My girlfriend likes to joke that this laptop has a GCS of 3. The chair you're sitting in has a GCS of 3. Like that's the type of things we're talking about with there.
And just for plug number 2 of the podcast, Mike did make a nice little post about that today. Yeah. So check out Instagram if you want to see a breakdown of the Glasgow Coma scale.
Yeah, that was great. It looked great, and it's routinely done too. They'll have it out in the trauma bay and within the ED when you're assessing these patients, and you'll hear them say, "What did you get for your GCS?" So there's an old kind of medical dogma situation too that we sort of live by. The lower the GCS, the more you're not able to maintain your own airway. So the old Amish is GCS of 8, intubate, and so you'll see that and hear that quite a bit. So for this patient initially with a GCS 11, I'm not thinking he needs to be intubated initially, but if he starts to deteriorate, which we see later on within the patient case he does, this calls for him to be intubated. Now, as a pharmacist, what's important to me when the pre-hospital stage is how are they assessing this GCS? So per the TBI guidelines and per the emergency neurological life support course that is sponsored by the Neurocritical Care Society, they say not to assess assess the GCS until you've actually resuscitated this patient. So that means give them oxygen, give them fluid if they need it, if they're hypotensive. So that is something I would want to ask is in the field, this GCS is 11, but is this, at what stage is this?
Right.
Also too, again, just not to hit it home on the head though, but this guy has alcohol on board. So it's tough at that point to fully appreciate what his GCS is. So in my head, as they're coming and they're on the bus trying to get to the hospital, I'm trying to think, okay, so what is he going to need? It sounds like he may have a TBI. It sounds like maybe at this point, he may be a little drunk. So I need to think about those things. So he may be combative. So I have to think about what agents can I use that will not affect him if he is agitated, and then affect his secondary injuries at this point. So for for this, now that I hear his GCS is 5, at that point, I'm going to think about the meds that I'm going to want to use for rapid sequence intubation. And there's been a lot of debate in terms of which medications have increased associated mortality with it. Some of the neuromuscular blockers have an increase in the amount of mortality associated with it, but it's all mixed data at that point. Probably the most controversial to date, too, for RSI meds would probably be ketamine. Ketamine initially in the 70s had some case series that were associated with some increases in intracranial pressure, which is happening with a TBI, and we'll get into that a little bit later. But that is, has since been debunked, and so that's why it's always important too to make sure that you're up to date with the literature on what you're trying to assess for. But in my head, I'm thinking, okay, so I need to make sure that this patient doesn't become hypotensive and he doesn't become hypoxic. Those are the two worst secondary injuries that I can have in a TBI. Hypotension, just one episode is associated with increased mortality. Hypoxemia is also increased with or associated with increased mortality. And so these are things that you have to think about for a patient that it has a traumatic brain injury.
Right, and they're looking at what, systolic less than 90 and O2 sats less than 60.
Yeah, so that's probably your best bet there in terms of judging these patients. But yeah, that's so the reason we do that is that in a traumatic brain injury, we're all the main goal is to maintain cerebral perfusion pressure, or CPP. So that is basically the pressure that is maintaining blood flow to your brain at this point. So yours and I's probably a CPP value of 60 to 70, maybe less when we're sleeping, maybe more when we're working. And so this is all functioned and basically controlled by our brain by a process called cerebral autoregulation. And that's basically your brain's capacity or ability to maintain that pressure with different variances in volumes. So I drew a crude graph here. I don't know if it'll show up, but hopefully it will.
Go for it.
Basically what you have here is your main CPP level, which we are trying to maintain at all times. Now, it does this by constriction and vasodilating the different arteries and the vasculature. It can do this with different variances in volume up to a point. And at that point, when it can no longer maintain that, you see a sharp increase in pressure. And the reason you see that sharp increase in pressure is because of a principle called the Monroe-Kelly doctrine. And the Monroe-Kelly doctrine is basically a fancy way of saying that your skull has a fixed finite amount of space. It makes sense, right? So we have this cranium, it has brain tissue in it, has blood, and a CSF. Well, obviously mine's a little bit bigger because it's like I have a big head, and that's just the way it is. But we all each have a fixed finite amount of space within there. Now, when you have a traumatic brain injury, it's just like anything else. It's just like when you sprain your ankle, there's increases in cytokines and pro-inflammatory markers that causes free water to shift into the cranium. Well, that's all well and dandy until we reach that point at which we can no longer auto-regulate using vasoconstriction or vasodilation, and we have sharp increases in intracranial pressure. Now, we said that the whole main goal for anything is for our brain is to maintain cerebral perfusion pressure. Well, the equation for that is cerebral perfusion pressure is equal to our mean arterial pressure minus intracranial pressure. So intracranial pressure increases as the amount of volume that's within the cap of the brain cranium increases. And so that is basically what I just showed you here in that graph, where you have a large volume increase within the cranium and then a large pressure increase.
Right.
And what happens there is you decrease blood flow to your brain, and at that point we expire. So those are your basically your main things you're trying to prevent as a pharmacist, is these secondary injuries with hypotension and then also hypoxemia, all based off of this. So if you get anything out of this podcast or lecture, it's that we want to maintain cerebral perfusion pressure.
Right.
Okay, that's a lot. And I know it's a lot.
No,
So
it's good, man.
one
That's
word
awesome. I'm
said to
learning
the
too.
other
This
word.
is
But
great.
So let's go back to this patient case. So the first thing I'd want to know when I start talking to paramedics or when he gets to my ED is, like you said, I want to know what his blood pressure is and if he's hypoxic. I also want to know exactly what I can intubate with or what I can't intubate with. And those are all discussions for like a whole nother time, but that's the main thing you're thinking about. So as a pharmacist, I can do pretty much two things at that point. I can make sure that we are giving him the most proper medications before we intubate him to make sure he's not hypoxic, and then I can also make sure that he's not hypotensive. We also have medications that I said that there's free water now into your cranium. We can give medications that will draw some of that fluid out, and that's called hyperosmolar therapy.
Right.
And that it basically is a treatment option or treatment therapy that essentially creates a gradient between our cerebral cavity and then also our intravascular volume. And I always make my residents laugh on this, and it's basically when you start talking about hyperosmolar therapy, I say if you had two trees and you had 74 squirrels on one tree and you had 3 on the other, what would happen? So the squirrels from the 74 tree would jump over to the 3. And that's exactly what happens with hyperosmolar therapy. You give a drug that has a lot more solute within the drug itself, causing the free water to shift. And that's exactly what happens. And so when that happens, you alleviate the pressure and the brain is able to auto-regulate again with the amount of fluid that's there, maintaining cerebral perfusion pressure.
So quick question. So is mannitol, I know, is one of the go-to agents. What about hypertonic saline? I've seen like some debate. This is totally not my area, so I'm literally asking for me too. But like,
Yeah.
I know there's a debate on like whether or not to use mannitol or hypertonic saline, and then like what concentration of hypertonic saline to actually use. Can you talk about that a little bit?
Absolutely. So hypertonic's probably my favorite drug. And that's something that if I could, as a pharmacy student, they don't really get taught that much, is that fluids are drugs. They serve a purpose to correct a medical issue. So pharmacy students and PAs, residents, all that, just know that fluids are a drug as well that you are actively involved in. But so the debate between hypertonic and mannitol, talking to a guy that's very pro hypertonic saline, there's really not much of a debate. The literature has shown that there's better associated outcomes with hypertonic saline use. Now, which one to use will depend on the severity of the injury. So if a patient has more severe brain injury and they have severe increases in intracranial pressure, you're probably going to use a more concentrated version of hypertonic. And so some of the considerations when you think about that is, do I have access? Do I have a central line? Because you're not going to want to give something that's super concentrated through a peripheral line. At that point, you're just going to blow the line. And at that point as well, the patient is going to start to extravasate and it's going to cause severe pain for that patient. So some of the properties that I like about with, and we'll talk about, I guess, the debate on hypertonic versus mannitol. The debate with hypertonic and mannitol is that they're both hyperosmolar agents. They both decrease swelling within the brain, and they do both cause decreases in intracranial pressure. But really, it comes down to, is the patient hemodynamically stable or not? So one of the ways that, or one of the other actions of mannitol is that not only does it draw solutes away from the brain, it also causes osmotic diuresis. And so when you have that, you're actually dropping your MAP, which we know is a big proponent of cerebral perfusion pressure, which is an issue. So if we're dropping our MAP, we're dropping our CPP, which is bad. Even if we're dropping the ICP, it's not good. You also have increases in renal failure associated with mannitol. You have some with hypertonic, but not quite as much as mannitol. And then the other big knock on mannitol is that it has a property called, it's going back to general chemistry here, but it's called your reflection coefficient, which basically just tells you a way something will distribute one way or another. So you probably did it in a chemistry class, oil and water. Mm-hmm. So a reflection coefficient of 0 means that it will freely pass from each solute or each fluid to each fluid. reflection coefficient of 1 means that it will not pass whatsoever. So the reflection coefficient of mannitol is 0.9. So you're like, oh, great, it's pretty good. It's not going to pass that much. However, when you have repeat doses of mannitol to treat intracranial pressures or elevated intracranial pressures, it actually will then start to cause what we call rebound intracranial pressures. It'll basically distribute into the cerebral tissue, drawing free water back into the brain. So there's a big issue in that. And so you basically are defeating the purpose of what you're trying to do. The hypertonic saline has a reflection coefficient of 1, so it's great. It doesn't freely cross. It's a volume expander, so you're going to increase your MAP and decrease your ICP. Really, the only patient population you probably wouldn't use it in is if somebody's already hyperkalemia. You can cause metabolic acidosis in that patient population. And then really the only other knock on hypertonic is that you do need peripheral or central access for anything greater than 3%.
Right.
There's been a lot of debate as to whether or not you can give 3% hypertonic saline peripherally or not. There's been really not any more debate on that because there's been multiple studies now that have shown that it's safe and effective at doing so. So I think that was probably initially patients would come into the trauma bay, you only have peripheral access. So it's like, oh, we'll give them a dose of mannitol. But it's really no debate now. I'm very comfortable with giving them 3% at that point. And then the other thing is whether or not a patient will require continuous infusion of hypertonic saline.
Yeah.
There's debate on that as well, bolus versus continuous infusions. And this is where you as a pharmacist just need to interpret the literature on your own.
Yeah, and to support your point about hypertonic saline, there was a small study published in Critical Care Med, CCM, back in 2003 by Violet and colleagues, I think is how you say his name. He's one of the authors. Very small, like 20 patients, but it was comparing mannitol to hypertonic saline, each given a dose and monitored and whatnot. And there was mean number and duration of recurrent elevated intracranial pressure episodes were higher in the mannitol group than hypertonic saline. So that's just one small study, but so I wouldn't.
There's actually been growing. So there's no mortality data ever going to be. So first of all, yeah, there's no mortality data associated with either agent, just because you're never going to do that study. Like it's just never going to get done. However, like you said, there is surrogate marker outcomes that have shown that hypertonic saline is better overall. I don't really think that there's there's some people that still want to use mannitol, but for the most part, once you show them the literature, there's really not a patient population you probably wouldn't use hypertonic saline in.
Gotcha. Cool. So hypertonic saline it is.
Nice.
Like I said, you could ask 3 or 4 different other pharmacists, they may have a different answer, but that's probably going to be the majority of their answers.
Gotcha. So that's the big thing. So what are the other things you're looking at as far as acute issues to address?
Yeah, so acute issues is maintaining, like we said, maintaining blood pressure, maintaining adequate oxygenation. If they have any signs of impending herniation, if they have what we call the Cushing's triad, which is agonal respirations, hypotension, and then tachycardia, that's signs that they're about to herniate through their skull. And at that point, when you do that, you end up with death at that point. So yeah, we're looking at, do we need to give hyperosmolar therapy now? Do we need to hyperventilate them? Things like that. The other things is these patients have increases in metabolic disturbances. They have increased excitatory neurotransmitter releases during the acute phase in the first 7 days after injury. So you have to make sure that these patients are getting seizure prophylaxis at this point. And then there's been studies that have looked at, do I use phenytoin? Do I use Keppra? Or levetiracetam? Do I use another agent? And for the most part, the data is leaned towards the use of fosphenytoin, with Keppra a close second. There's probably institution-based and also probably surgeon-based or trauma surgeon or traumatic intensivist-based that will pick either one. I'm okay with either as well. I probably would choose levetiracetam over fosphenytoin or phenytoin, just due to ability to give it faster and for drug-drug interactions. But
And lack
that's
of
just me.
and less kinetic equations too, right? Because you know,
Kalis Minton, yeah, he
yeah.
comes back.
So like,
So yeah, that's
with the as far as like phenytoin, if I remember correctly, if you have to obviously do to draw levels, you have to do kinetics equations and figure out dosing and see if you need to go up or down or keep it as is. When you draw a phenytoin level, isn't it the free phenytoin level that's typically drawn? It gives you a more accurate picture. Is that correct, or am I just making that up?
yeah. So I mean, you can. So we'll get into, but yeah, you can draw the free, and it's actually you don't have to do quite as much calculations, and you don't have to have an albumin to basically correct for it. But actually, when you are dosing for seizure prophylaxis and TBI, we're actually not drawing levels. We're actually okay with just a flat. Usually, it's 100 of phosphatidylcholine 3 times a day, or if they're able to take oral at that point, we'll do. My institution will do phenytoin 300 milligrams at night because it's a little bit more sedating.
Gotcha.
But yeah, we're not drawing levels at that point on these patients because it's just prophylaxis. They're not actively
Right.
seizing.
Gotcha.
Right.
Makes
And
sense.
it's just for 7 days. There was a large study done. It was published in New England, and I think it was right around 97, 98, something like that, that showed that basically seizure prophylaxis extended past 7 days had no benefit. These patients that were going to seize, they were going to seize either way, whether they were on prophylaxis or not. It's actually a bad sign when a patient is seizing early on in traumatic brain injury. So those are things to think about as well. At that point, we may actually start to draw levels to make sure that we are therapeutic if they had actively seized before. But again, if the patient has blood on their brain, that is going to cause them to seize. So if we can get rid of that or manage that, hopefully we've managed their seizures at that point too.
Gotcha. Cool.
Um, Other things to think about for these patients too is if they are intubated, that you want to make sure that they're sedated, and they're also at this point they're also a trauma patient. So he's got this patient has rib fractures, so increased pain levels is also associated with increased intracranial pressure. So I want to make sure that their patient is monitored and sedated properly, where we're not dropping MAPs, but we're also maintaining low levels of sedation so that we can do more frequent neurochecks if we need to. And like I said, make sure we're adequately treating this patient's pain. So those are other things to think about. So those are all different things that pharmacists really can make an impact on early on, is getting them on the right sedative and then getting them on the right pain regimen as well.
So, real quick, but what do you what's kind of the options for sedation in these patients?
So when you start, you have to start thinking about the ideal characteristics of these agents. So fast on, fast off is great. So I can do these neuro exams. And then I would like something that is going to not accumulate or affect anything hemodynamically wise. So when you start thinking about these agents, propofol is probably up there for a majority of people. It's fast on, fast off. Only problem is that you're looking at, it does drop MAPS, and it can cause decreases in heart rate. So you're worried about hemodynamic stability at that point. A lot of people too will look at ketamine. Ketamine's been making a really big comeback right now. Ketamine's great because it gives you not only sedation, but it gives you some pain as well. And it also acts on NMDA receptors, so you actually have some anti-seizure properties as well. So ketamine's really the Swiss Army knife of like your drugs in the ED. It does a little bit of everything. So we've been pro ketamine and using quite a bit of it here, especially with the opiate shortage. So it's been a good agent to use. The other thing you can think about is analogous sedation, which it's hard to push right now when there's such a shortage of opiates, fentanyl, hydromorphone. Some people will still do morphine drips. We tend to stay away from those just because of the hemodynamic instability of that agent, but those are also options. You can also use things like Precedex for a little bit lighter sedation. It's also a pretty decent choice. Has opiate sparing activity as well. Also, you have to worry about it with hemodynamic instability. I would say the majority of people have in the trauma world, especially for TBI, have steered away from midazolam drips, lorazepam drips as well, just because it's so lipophilic and you have it on. It stays on for such a long time, and it's so difficult to get neuro exams with those agents. But I'm sure that there may be some institutions out there still doing it. Hopefully not, but maybe they listen to this podcast and they stop doing it and they switch to like propofol or
changing protocols. No, that's awesome.
Hopefully.
Man. Well, and I'm just trying to think of random things that I remember from my rotation just to get some clarification. So maybe it'll help a student who's not trained in this area but has a rotation or something. Lorazepam IV, when they're getting it like that, isn't that the one that we're worried about? Propylene glycol.
Yep. Yeah, we absolutely can have that, and that is so if you are monitoring in these patients. Usually if they're intubated, obviously, hopefully they're intubated if you're giving them a lorazepam drip, and you'll start to see that they're acidotic without any sort of explanation. And at that point, you'll check a lactic acid. And if their lactic acid is elevated, that goes back to the old mud piles thing. So, and that's on your radar. But yeah, that's one of the reasons we try to stay away from it. But, in this guy, it's, IV lorazepam for somebody that has some alcohol on board. We're not really sure of his intake. Then you start worrying about, is he going to withdraw if I take away that GABAergic type of regulation he was having? So yeah, maybe a PRN boluses of it. But at that point, you would hopefully have a better history. But sometimes you don't.
Right. Cool.
So what else? We talked about seizure prophylaxis. We talked about sedation.
Talked about intracranial
pressure. Is there any other big aspects?
Yeah. So, you could go all day with it, but yeah. So you're also thinking about correcting these patients' coagulopathies.
Okay.
So they will all typically, nowadays most of your level 1 trauma centers are getting what we call TEGs or thromboelastographies, which are basically a printout or a representation of their clotting cascade from start to finish. And so that you'll try to treat the underlying coagulopathy if needed, especially too if they're a patient that's on like Coumadin, or if they're on one of the DOACs, like at that point you would have to correct for that as well. So you see a lot of those. You'll have a lot of DOAC or warfarin-associated head bleeds as well that are traumatic in nature because they fell and they were on warfarin and now they have a subdural hematoma and a subarachnoid that they're bleeding into their brain. So you'll have to correct for that. You can use, right now, pretty much all the literature is pointing towards prothrombin complex concentrate or PCC. Most centers are using Kcentra at this point. So you can do that. That's also something the pharmacist is very heavily involved with. And there's been more and more emerging literature on the use of, and you'll probably start to see it too with in the next 2 or 3 years, but fixed dose versus what the manufacturer is recommending. Manufacturers recommending like huge doses for these patients, whereas there's been 2 or 3 really small studies one of them was out of Canada. I can't remember what the other one was, but they were using just sort of these fixed dose. So the 250 pound patient was getting the same as the 110 pound, elderly lady. Right. So it's interesting. And then some of the other things too is, hyperthermia. We want to correct and keep them euthermic. There's been some literature on, do we cool these head patients? Do we not cool them? And it's pretty mixed at this point, depending on where you go. Some of them may have a cooling protocol, but I don't think that there's any debate that hyperthermia for these patients is bad. Or is good. So they will correct for that. But those are some of the things that if we're scheduling antipyretics at that point, or if we're trying to does this patient have an infection at this point? So those are all different things you have to think about. And then as the pharmacist, what's their mechanism? So are they febrile because of the trauma? Are they febrile now because he's got broken ribs and he's got atelectasis, he's not moving air as well? Or is it he has rib fractures and now he has a pneumonia on top of his traumatic brain injury? So these are all different things that we can look at as far as treatment and things that we are very heavily involved in.
Yeah.
Yeah, that's awesome, man. Well, I'll tell you what, we got to kind of wrap it up, but I think that if you're interested, we probably need to do a part 2 at some point, because
listen, I can talk about this stuff all day, man.
and it's awesome because I'm learning sitting here too, so this is great for me. And like I was saying originally, I don't have any experience with this other than like my one rotation. This is totally out of my field, so this is great. I'm like super interested just listening, and you can tell you're really passionate about it too, which is great, because you can tell like there's some people that it's like critical care, whatever. You like love critical care, you can tell. It's great. That's awesome, man. We'd love to see that. So yeah, I mean, if you're interested, we'll definitely have you back on soon if you want to, and talk some more, because I think we definitely have a ton more to cover. We got to keep it somewhat in the time frame before everything starts shutting down due to battery life.
Absolutely, yeah.
But yeah, if you're interested, man, we'd love to have you back, and I really, really appreciate you taking the time to do this with us.
Absolutely. Thank you. Thank you for having me. I really appreciate it. You guys do good work.
Thanks, man.
Appreciate it, man.
If a student or anybody wants to get in touch with you or has questions for you, do you want to give your email or something to?
Yeah, I'll send it to you. You can put it up with the post if you want. Yeah, they can absolutely shoot me an email. Absolutely. So part of what I do as well is I take on residents, I take on students, and it's part of the job as well. So absolutely.
Awesome.
All right. So we'll do that. So if you guys have questions, make sure you email Brian and not me or Cole, because he's gonna have better answers than us. And we'll do that, and we'll put it on the website. Brian, again, man, really appreciate you. If you guys enjoyed that, please leave a comment. Also, Brian has some social media stuff. I'm sure he wouldn't mind you following him if you're going to reach out to him. And make sure you leave a comment, subscribe to the podcast, and we will try to include a lot more critical care concepts onto the Instagram and the flash briefings for Amazon's Alexa, things like that. So, Brian, good talking to you, man, and we'll keep in touch.
All right. Thank you, guys.
All right.
Thank you.
Thanks, everyone.